Hi, everyone. I'm Elizabeth Lamack. I am a GU medical oncologist here at Fox Chase Cancer Center in Philadelphia, US. And I am joined by my colleague, urologist Axel Merseberger. And we are here to talk to you about what we see as the highlights that came out of the ASCO meeting. We have too short a period of time, obviously, to cover everything of interest to both of us, but we'll start with a couple that are compelling. So, Axel, what did you think of the neoadjuvant bladder sparing approach? Matt Galsky presented a clinical trial that he completed looking at nivolumab in combination with gemcitabine and platinum, followed by sort of decision making, shared decision making about whether patients should keep their bladder or not after treatment based on a clinical response. What are your thoughts on that, and how has the urology world sort of absorbed that data?
Well, thanks a lot for including and inviting me. I mean, it's for bladder cancer, this year's ASCO virtual meeting didn't really deliver any game changers. And I think it's always the other way around. One year you see game changers, and the other year you see some hypothesis generating presentation. And I think this was the year of novel ideas and very interesting ideas. And those were like the three neoadjuvant abstracts. You're mentioning the one by Matt Galsky, the phase 2 trial, gemcitabine, cisplatin plus nivo in selected patients. I think it really shows that this combination and this neoadjuvant approach can preserve the bladder in about 50% of the patients. So for me, I think it is very important that we work together closely and not post cystectomy or in metastatic disease, but before that. I think that's why I was very happy to have this webinar with you together to exchange our views. And when looking at the phase 2 trial presented by Matt Galsky in detail, the patients received GemCis and then 4 cycles in combination with nivolumab. And then when they had clinical complete remission defined by imaging, defined by urine cytology, which I think it's a very urologic approach, and then bladder PEs, so biopsies. This resulted in 30 patients with bladder conserved compared to 33 patients with a non-clinical complete response, which underwent radical cystectomy. So I think it's a very good result. And also when looking at the swimmers plot, and I think for those phase 2 trials, I really like those swimmers plots because you can individually look at the patients, what happened. You also see this one patient that wanted to get the cystectomy that dropped out. So I think it's good sign. Surely we as urologists, I would like to see more robust data, phase 3 trial data, which will come. But I think it is something we have to discuss nowadays with our patients. And this is also what we do. We have large neoadjuvant trials right now. And me as a surgeon, I experience very good surgery results after neoadjuvant treatment with those modern combinations. I mean, they're not published yet they are still running, recruiting, but like from our own experience in our center, and we have 3 of those trials open right now. It is very interesting, and I think a modern approach to muscle invasive bladder cancer.
Axel, do you notice any difference surgically? Is the surgery more or less complex following an immunotherapy-based neoadjuvant combination versus your years of experience with neoadjuvant chemotherapy?
No, I think what is worse is when you have a salvage situation, when you have progressive disease post chemotherapy or trimodality treatment post radiation. This is somehow complicated and it's not fun to operate. But in the classical neoadjuvant approach, regardless of a triple combination or double combination, it's not a problem. The only thing we had some issues with healing and with abdominal wound infections that we have but some obese patients. So I think this is the only thing, but otherwise it's even easier to operate.
That's great because we also saw Sam Funt presented a clinical trial of Gemcis plus durvalumab in the neoadjuvant space with really compelling clinical, pathologic complete responses. In that trial, everyone had their bladder out. And of course, patients with clinical complete responses or pathologic complete responses in the bladder really do well in terms of survival. So I think we all together, urology and medical oncology, share the goal of keeping bladders in place only when it's safe to do so, but not at the expense of cure. And I'm hopeful that these neoadjuvant chemo combinations with IO will elevate that. There's always a question of whether moving IO with chemo, the phase 3 trials in the metastatic setting didn't show that to be beneficial. I usually just say the neoadjuvant space is different, always has been. And so if IO gives us a boost to cure in that space, I think it's something we'll be doing. So we have trials at our site too, looking at that. It's like the next frontier. So Axel, let me also ask you, this is going back to GU ASCO. There is a large randomized phase 3 trial that was positive for DFS, nivolumab in after cystectomy in high-risk patients. What were your thoughts on that, and how do you think that will enter clinical practice on the urology side?
Yeah, heavily discussed at the beginning of this year. We had this atezolizumab trial last year negative. Now we have the Checkmate 274 trial with nivolumab positive with regards to DFS. I think prior to approval, or when we have approval, we have to discuss with the patient also the situation of the subgroups. There was a large proportion of upper urinary tract cancers with the mixed response in this situation. So this is more aggressive tumor. I think we need to treat different. So the subgroups are still under discussion. Surely we have to discuss the overall survival and wait one positive trial versus one negative trial. Also within the sequence, since now we have the switch maintenance concept, giving patients in the situation once they progress, once they have a recurrence, chemotherapy, best cisplatin, and then second line, the avelumab maintenance treatment. So if we would have given nivolumab before, after surgery, what is your perspective on the sequence? It's really, really tough. You only have EV, fortunately approved in the US, but we are lacking here. So I think this is it's not a clear cut the data on nivolumab adjuvant. It has been discussed, and we have to look at the subgroups. And personally, if I would see a signal in overall survival, this would convince me more. What is your perspective of this data?
I completely agree with you. So I'm a stickler for overall survival. I feel like we will have more effective combinations in the metastatic space because we're studying that so much deeper than the adjuvant setting. So we're always a little bit behind. So single agent checkpoint, for instance, has fallen a little bit out of favor in the metastatic space in favor of javelin approaches, EV pembro combos. But that's what we will be using in the adjuvant space if OS is achieved. So from my perspective, we have to be curing more people to justify both over treatment, right? Treating those patients who actually you've already cured with your surgery, but are technically at high risk statistically. So we have to justify that, justify the immune related adverse events, some of which can be chronic, although they aren't that common. And then weigh that against sort of the more effective combinations that we hope to have in the metastatic space. So I agree with you. I would wait for OS before recommending it.
So what is also under discussion here in the community in Europe is the question when you have cisplatin ineligible patient in the event of metastatic disease, what to give first. So let's pretend you have a positive biomarker. Do you want to give pembro or atezo? I think you also have nivo approved, or do you try to get split dose cisplatin or carboplatin? So the decision carbo or IO, how do you weight your decision or how do you decide?
Yeah, that's a great question. And really our sort of approach to the frontline metastatic setting has not really changed for platinum eligible patients. Our recommendation really always was platinum-based chemotherapy, highest response rate. There are durable CRs, not so much talked about, but to cisplatin. Once you go to carboplatin, we don't see durable CRs, and the response rate is much less. But with the evolution of all the data that we've seen from the large randomized phase 3 chemo combo trials, from Javelin 100 and from sort of the longer follow-up of the single agent checkpoint trials in the newer studies, I think the way I put it together is the following. Gem carbo still has a higher response rate than a single agent checkpoint. We know from Javelin 100 we can give it for a fixed period of time before then moving on to maintenance checkpoint. And we know that by giving chemo up front, we give our patient the best chance of long-term response to their checkpoint inhibitor. And we've shown that in multiple studies. So based on just the efficacy data for a patient who's eligible for carboplatin or a single agent checkpoint, regardless of PD-L1 status, I would recommend gem carbo, again, followed by the avelumab maintenance approach. There's a rare sort of sliver of patients in my practice. It's patients who are older, multiple comorbidities, very high PD-L1, very low disease burden. So that patient is someone I might consider for a single agent checkpoint up front, accepting the lower response rate because of the lower disease burden, knowing that they're likely to respond based on their PD-L1 status. And looking at all the different trials together, I usually use atezolizumab in that space because the curves did not inflect when compared to chemotherapy, meaning there wasn't that short period of time at the beginning where the chemo patients did better in the PD-L1 high atezo patients. So that's how I look at it today. I think there was some data at ASCO that might upend that, and I hope it does, right? We do this to sort of always be changing what we're doing. And those data were the EV Pembro data. So that was a small cohort of about 45 patients treated in the frontline setting with enfortumab vedotin and pembrolizumab. And we saw amazing responses initially in that group. And the update at this year's ASCO was that those are largely maintained. So not only do we see the majority of patients responding, but that they're responding for relatively long periods of time. Now, the average median overall duration of response was 25 months compared to 20, which was the median follow-up. So we haven't even followed up people long enough to see.
For the listeners, is it platinum eligible or ineligible?
So that's a good question. Platinum, cisplatin ineligible, platinum eligible.
That's the question. Since it's ineligible, you are somehow stuck afterwards what to give. So is it FGFR afterwards, or what is your solution after this situation?
Whenever we invent something better in frontline and it combines agents we use later, we're always stuck with this question. So I'll just say that's a great one. It's a good problem to have. I think if you use EV and Pembro up front, then there's no reason not to circle back to some of the cytotoxic chemotherapies. These are patients who could get gemcarbo and might do well on those later. We do have erdafitinib, but I mean, that's a sliver, as you know, of patients who are FGFR positive. So I guess what I'll say is I'll take that, it's a good problem to have if patients do great on their first line. And hopefully we'll have more novel agents to use subsequent.
Thanks a lot on your insights. Before we have to stop due to time limitations, may I just due to curiosity ask you about your clinical experience, since unfortunately EV is not approved as of yet in Europe. We see the data at ASCO GU, we read the publications. I have one patient with a great response where I fought through all the instances with regards to approval and cost, and we ordered it from international pharmacies, so it worked and I got a good response. But how is your treatment, let's say, sequence with EV? When do you start in your clinical practice? So I've learned from you, if possible, cisplatin first in combination with gem, and second line then, for example, pembro as IO with robust evidence. And what's third line? Do you all test for FGFR and then decide EV or FGFR, maybe as a close statement from your side? And thanks a lot.
Yeah, no, that's a great question. So we do test for FGFR early. I will say, even in the FGFR positive patient, I usually recommend the EV first. It has a really great response rate, a nice durability of response. But again, for the patient who has a choice between the two, it's obviously discussion. I'm sorry you don't have EV in Europe. It's very effective. It's especially effective in liver metastases. It's definitely helped people with urothelial cancer live longer. So all I can say is I think the data are strong enough that ultimately EU will approve it, and that you'll be able to give it to more of your patients. But it's a really important tool that we use in most of our urothelial metastatic patients these days.
Well, thanks a lot. I would have loved to chat much longer with you on this exciting topic. Hope to meet virtually at ESMO and hopefully face to face again at ASCO GU next year when pandemic has eased. Thanks.
Absolutely. Great talking to you, Axel. Thank you.